Pituitary adenomas are the most common cause of pituitary hormone hypersecretion and hyposecretion in adults. They account for about 15% of intracranial tumors with a prevalence of 80 per 100,000 population. Most adenomas are monoclonal in origin and arise from somatic mutations. Hormone secretion is often independent of tumor size. Pituitary adenomas are classified as functioning or non-functioning tumors. Functioning tumors secrete hormones while non-functioning tumors often present with mass effects. Key molecular drivers include GS-alpha mutations increasing cyclic AMP signaling. Other pathways include EGFR and tumor suppressor loss such as MEG3. Familial syndromes include MEN1, Carney complex, McCune-Albright syndrome, and AIP mutations in familial acromegaly. Hyperprolactinemia is the most common pituitary hormone excess. Causes include prolactinoma, drugs like antipsychotics, and stalk compression. Women present with amenorrhea, galactorrhea, and infertility. Chronic hypoestrogenism leads to reduced bone mineral density. Men present with decreased libido, impotence, infertility, and sometimes visual field defects due to macroadenoma compression. Prolactin above 200 micrograms per liter strongly suggests prolactinoma. Levels below 100 micrograms per liter suggest non-neoplastic causes. Prolactinomas are the most common functioning pituitary tumors. Microadenomas are usually non-invasive, while macroadenomas may compress the optic chiasm. Cabergoline is first-line therapy at 0.5 to 1 mg twice weekly. It normalizes prolactin in 80% of patients and shrinks tumors in 70%. Bromocriptine is an alternative dopamine agonist started at 0.625 to 125 mg at bedtime. It is preferred in pregnancy planning. Transphenydyl surgery is indicated for dopamine-resistant prolactinomas. Normalization occurs in about 70% of microadenomas and 30% of macroadenomas. During pregnancy, estrogen causes pituitary enlargement. Macroadenomas enlarge in 15 to 30% of cases and require close visual monitoring. Acromegaly is caused in over 98% of cases by GH-secreting pituitary adenomas. It results from excess growth hormone after epiphyseal closure. Clinical features include enlarged hands and feet, prognathism, frontal bossing, and soft tissue swelling. Cardiomegaly and sleep apnea are common. Diagnosis is confirmed by elevated IGF-1 levels. Growth hormone fails to suppress below 0.4 micrograms per liter after 75 grams oral glucose. Transphenydyl surgery is first-line therapy. Remission occurs in 70% of microadenomas and less than 50% of macroadenomas. Somatostatin analogs like octreotide LAR normalize growth hormone in about 50% of patients. Pegvisomant normalizes IGF-1 in up to 70%. Acromegaly increases cardiovascular mortality nearly threefold. Untreated disease reduces life expectancy by about 10 years. Cushing disease is caused by ACTH-secreting pituitary adenomas. It accounts for about 70% of endogenous Cushing syndrome cases. Clinical features include central obesity, purple striae, hypertension, and proximal muscle weakness. Psychiatric symptoms are also common. Diagnosis begins with 24-hour urinary-free cortisol or overnight dexamethasone suppression test. ACTH level determines dependence. Transphenydyl surgery achieves remission in about 80% of microadenomas. Recurrence occurs in around 5% of cases. Medical therapy includes osilodrostat 2 to 30 mg twice daily and ketoconazole 600 to 1200 mg per day. Monitoring is essential. Aggressive adenomas have Chi-67 index greater than 4% and may require temozolomide therapy along with repeated surgery and radiotherapy. Non-functioning pituitary adenomas usually present with mass effect symptoms like visual field defects and headaches due to optic chiasm compression. Diagnosis relies on MRI imaging and hormonal evaluation. These tumors are often large at presentation because they lack hormonal symptoms. Transphenydyl surgery improves vision in about 70% of patients. Recurrence occurs in approximately 15% within 5 years. Thyroid-stimulating hormone-secreting adenomas cause secondary hyperthyroidism. Free T4 is elevated with inappropriately normal or high TSH. Management includes transphenytal surgery and somatostatin receptor ligands. These agents normalize TSH in most patients and shrink tumors. Aggressive adenomas show rapid invasion and Ki-67 index above 4%. They often require multimodal therapy including temozolomide. Long-term follow-up is essential with periodic MRI and hormone profiling. Recurrence may occur even years after surgery. Pituitary adenomas require integrated surgical, medical, and radiological management. Early detection improves outcomes and prevents irreversible complications.